Μπορούμε να προχωρήσουμε στην επόμενη διάλεξη, η οποία θα δοθεί από τον Άντρου Davenport, ο οποίος είναι Past Director, International Society of Hemodialysis, Editorial Board, Kidney International, Nephron, Clinical Practice, Blood Purification. Είναι Committee Member της International Society of Blood Purification, Acute Dialysis Quality Initiative, Acute Kidney International. Το θέμα για το οποίο θα μας μιλήσει είναι πάρα πολύ ενδιαφέρον. Είναι ένα θέμα το οποίο παλιά μας κινούσε το ενδιαφέρον για τη διάρκεια της αιμοκάθαρσης. Επομένως, το θέμα για το οποίο θα μιλήσει είναι dialysis duration, the longer the better. Dr. Davenport, good morning.
Morning. Thank you for the introduction. Fortunately, I couldn't hear it because I couldn't translate it. It's not me. I'm just a very simple kidney doctor who treats patients. But we've heard some talks already this morning, and we've heard the audience all saying that more time is important. But is it? Sometimes things that we think are straightforward and obvious are not always what they seem. So first of all, let's go back to some data from Ray Van Holder's group. This was using the Genius system. The Genius system uses a single batch of dialysate, 90 litres. And they chose to dialyze patients for 4 hours, 6 hours, or 8 hours using the single batch system. The urea reduction ratio is the same whether patients are dialyzed for 4 hours, 6 hours, or 8 hours. So those of you who believe in long hours dialysis will turn around and say, well, most of the toxins of nitrogen waste products are in the cells. They're not in the plasma water. So time is required to remove solutes. And that's what they found, because one of the advantages of doing a batch dialysate is that one has a batch of spent dialysate at the end of dialysis. So when they actually measured urea, creatinine, phosphate, or beta-2 microglobulin, there was more in the spent dialysate in patients who dialyzed for 8 hours compared to 6, compared to 4. So time certainly improves solute removal. But does it improve survival? So you can go to the literature and you can look at lots of papers. And here's a paper from Bob Lindsay's group looking at the outcome of intensive dialysis, which was defined as more than 5.5 hours per session for at least 3 or to 5 times per week against conventional dialysis. And yes, the intensive group survived better. But all these studies are confounded by the patient selection, because the patient who opts for intensive hemodialysis is not the person who goes for conventional dialysis. There was one study published last year, this one from Jun, and what they tried to do here was to compare patients who'd planned to have more frequent dialysis. And some of the patients actually then went on and had more frequent dialysis, the as-treated group. But some of the patients who had initially said they wanted more frequent, more dialysis, didn't do it. And that is the intention to treat group. And you can see there's a slight difference in outcome. But again, the issue is, were the two groups totally comparable? Why was it this group didn't go on to have more frequent dialysis? And just to put it into perspective, this is the UK average 5-year survival on hemodialysis. So again, these patients are totally different to the average patient on dialysis. And therefore, what applies to these patients may not apply here. So to get around that, the Americans did the more frequent nocturnal and daily dialysis studies. The term in America for the average person on the street, the average man, is Joe the plumber. So the idea behind this trial was, if you give more dialysis to the average dialysis patient, do they do better? Does it make Joe the plumber better? And you can see what happened. They screened over 6,000 patients. Almost 3,500 patients ticked all the boxes in their inclusion and exclusion criteria. Over 3,000 patients were asked for consent. Less than 400 consented, less than 250 actually went into the study and were randomized. So you can see 4% of patients actually went into the study. And if you look at the age of the patients, in the nocturnal trial, the mean age was 53, it's 51 in the daily trial. And the weight of the patients, certainly for the US, is actually quite low. So these patients who actually went into the trial were certainly not the average US patient. So, we are told that more frequent and longer dialysis has advantages. We are told it has cardiovascular advantages. We're told there's less interdialytic weight gain. It should be interdialytic weight gain. Blood pressure control is easier. It's better if patients dialyze more frequently and for longer. We're told that left ventricular hypertrophy gets better. We're told there's less intradialytic hypotension, there's less so-called cardiac stunning, and there's also less cerebral stunning here. This is a brain with multiple infarcts due to repeated episodes of hypotension. But what were the actual findings? Well, this is the finding in the nocturnal limb. This line here is the normal left ventricular size for men, this for women. If you look to the left of that, for patients who started the trial essentially with normal sized hearts, there's no improvement. If you look to the right, so these are patients who start the trial with very severe left ventricular hypertrophy, there is a trend for an improvement. But two caveats. Firstly, this is the 95% confidence limit, which is over the line of 0, so statistically there was no improvement. Statistically, there was no improvement. And secondly, the other thing you need to remember is this. When you're doing more frequent studies, when do you investigate patients? Because if you're dialyzing somebody 6 times a week, the gap between the last dialysis session and the cardiac MRI scan is much shorter than if you're only dialyzing 3 times a week. And one of the places that patients put fluid between dialysis sessions is actually into the heart itself. And actually, if a patient puts on about 2 kilograms between one dialysis session and the next, it will increase the left ventricular mass measured by MRI of about 30 grams, which, if those of you who remember, was exactly the amount of weight reduction of left ventricular mass in the New England Journal paper. So there is a caveat. Now, for those of you who think that more frequent dialysis is better, then you can turn around and say, well, actually, although patients were told to dialyze 6 times a week for 379 minutes on average, only 61% actually dialyzed more than 27 hours per week. So not everybody followed the instructions. So what happened with blood pressure? Well, we don't know from the nocturnal trial because most patients dialyzed at home, so there are no records. There are some records from the daily trial which showed that there was a significant reduction in intradialytic hypotension. And the ultrafiltration per session was about 3.1 litres down to about 2.1. However, if you look at the actual amount of fluid in patients prior to dialysis, extracellular water, this is the nocturnal group 3 times a week, this nocturnal group 6 times a week, there is no change in extracellular water with more frequent dialysis in this American study. And yet you would have predicted that more frequent dialysis should have meant that the patient started dialysis with less extracellular fluid overload, not proven. And actually, if you looked at the number of actual episodes of hypotension, not percentage, but the actual numbers, you found that in the daytime trial, there were almost 460 episodes in the 3 times a week dialysis compared to 700 in the 6 times a week dialysis. So there actually were more episodes of hypotension in the more frequent dialysis group. Now, what about residual renal function? We've just had to talk about hemodiafiltration. If we can keep the kidneys working longer, patients tend to survive. So there are studies showing an association between patients who preserve some degree of residual renal function out-survive those who lose residual renal function. So what happens with more frequent dialysis and residual renal function? Well, what we'd expect is that more frequent dialysis would have less hypotension and would preserve residual renal function. But this is what happened. This is the nocturnal dialysis group. If you concentrate on black, because black is anuric, not passing any urine, all patients were passing urine at the start of the trial. But you can see here that the black bars suddenly appear much quicker and higher in the group who were treated more frequently. And this was statistically different. So actually, in this study, more frequent nocturnal dialysis resulted in quicker loss of residual renal function, not what you would have predicted. But that's why studies are done. So were there any advantages? Surely there must be advantages in terms of solute clearance. Surely we must have got better solute clearance with more frequent dialysis. Well, what about phosphate? So this is the adjusted mean. So what do you mean by adjusted mean? Well, again, it comes down to the issue of when you take the sample. Because obviously if somebody's dialysing 6 times a week, the gap between the one dialysis session ending and the next dialysis session starting is much shorter. So you have to adjust the measurement of phosphate for the frequency at which patients are having dialysis. So if you look at the adjusted mean phosphate, there is an initial fall in the patients who dialyse 6 times a week. But thereafter, it's not statistically different. Now, those of you who believe that more frequent dialysis clears more phosphate would turn around and say, well, okay, yes, we expect the phosphate to drop initially in the more frequent dialysis group, but then perhaps these patients ate more. It was a nutritional thing. The phosphate goes up because they're eating more. Well, what's the evidence for that? Did they all turn into Arnold Schwarzenegger? No, they didn't. There were no differences in albumin, protein-creatinine ratio, and on bioimpedance, there were no changes in muscle mass or fat in terms of body composition, either for the daily dialysis group or the nocturnal dialysis group. So patients didn't improve nutritionally. Well, we often turn around and say, if a patient has restless legs or problems sleeping, they're being under-dialyzed. Give them more dialysis. So what happened to sleep and sleep problems? Well, this is looking at patients dialysing 6 times a week for around about 6 hours or so. So this is long, more frequent dialysis. Were there any improvements in terms of sleep symptoms and sleep problems? No improvement. So more dialysis did not improve sleep. What about how patients felt themselves in terms of physical health? No difference. How about mental health? How about, did people feel less depressed by having more dialysis? No. What about, did the brain work better? Removing all those extra toxins, surely the brain must have worked better. But no, trial making, B-test, no difference. And there were some other tests they also did. No difference in brain function. Are there any disadvantages? Well, of course, most of this dialysis takes place at home. And they've just published a paper in C. Jason this month, again showing about the psychological effects to the home dialysis patient and also their patient, their partner or their family. And actually, if you look, this is the short form 12 physical score. Fortunately, the carers tend to score higher than the patients. Hooray. But if you look at the mental score, no difference. The relatives or carer of these patients, they're equally affected, with 25% having some form of depression and almost 10% having quite severe depression. So there is a downside to this more frequent nocturnal dialysis. So let's look at the coin the other way around. Why didn't Joe the plumber get it any better? Can there be some disadvantages of doing more dialysis? Now, there are some things we can think about. Sure, if we do more dialysis, yes, we're going to lose more blood in our filters. Yes, we'll need more iron. We can turn around and say, well, we would have expected from the North American data to have low phosphates. We could get changes in cations. And also, especially in the US, where they use lots of bicarbonate, very high bicarbonate concentrations, it could be there are problems giving relatively low potassium, high bicarbonate dialysates. Because there were 4 sudden deaths. And we just wonder whether they're due to hypokalemia, due to using supraphysiological bicarbonate and a low potassium, which is what the US often does in terms of how they dialyse patients. And then you can think about, well, of course, if we clear solutes, we could clear drugs like antibiotics, anticonvulsants, narcotics, those sort of things. And we could possibly remove some nutritional things, albumin, a bit more amino acids, water-soluble vitamins, carnitine, trace elements, etc. So we could remove some nutritional aspects. And then, of course, you're going to expose patients to more heparin, aren't you? So this is a DEXA scan, a bit of osteoporosis creeping in there, possibly expose them to heparin-induced thrombocytopenia with too much heparin. And then, of course, we often think about endotoxin in the water, because again, if you're dialysing patients at home, you can't provide the quality of water that you can in your main hospital dialysis unit. So this is just looking at nitrite contamination in some of our own water supplies. So there can be the concept of exposing patients to endotoxin or to chemical impurities in the dialysate. But is there really a dark side to dialysis? Are there things we're actually doing to patients which could be harmful? That's the real question. So some of you may have heard of this compound, bisphenol A. Very nasty, very toxic. And certainly in the laboratory, it comes out of your dialyzer. In clinical studies in humans dialysing, nobody's actually been able to show a change, but it's very reactive. So it's one of those compounds that you may not find in the serum because it's already reacted. What else? Well, if you don't wash out the circuit, then this is looking at the breath of patients when they first go on a dialysis machine. This is nonane, this very high peak, and this is dichloromethane down here. And they're not just the only organic chemicals that patients breathe out when they go onto dialysis. Here's a whole myriad of organic chemicals. Where are these chemicals from? Well, they're in the dialyzer. They're in the bloodlines. And if you don't wash them out, you're going to wash them into the patient, like this, a big splurge straight into the patient. And then, of course, you're thinking about repeated chemical exposure. We've got plasticizers like phthalates, biodegradable plasticizers these days, and some chlorohydrocarbons and organic solvents that you're exposing the patient to every time you put them on a circuit. And if you just take one of those plasticizers, diethyl hexylphthalate, it activates PPAR. And what's interesting is the actual amount of this chemical you can give a patient can vary dramatically from almost a very small amount, 0.3, to almost a half a gram per session. And where does this leaching come from? Well, it depends on terms of things like storage time, how long products have been stored, and also the temperature which they've been stored at. And two of the metabolites of DHEP, methyl ethyl hexylphthalate, and two, ethanohexanol, if you give them to animals such as rats or mice, they actually cause toxicity of the testis, ovary, kidney, and liver. And actually, if you go to the cancer registries, you'll find that patients on dialysis have an increased risk of kidney cancer, chronic myeloid leukemia, and hepatocellular or liver cancer compared to the general population. And the question arises whether it is this constant exposure to these sort of chemicals that increases this risk. And then there's another one that I quite like this story. So this was found by a Harvard professor of chemistry. He went and had a coronary artery bypass operation. And after the operation, he woke up and he found he'd lost his taste. So he went along back to his cardiologist and said, "I've lost my taste." And they said to him, "Oh, be quiet. The heart operation was fantastic. Just shut up. It'll come back." But it didn't come back. And he went and tried to find out why he should have lost his sense of taste. So he got one of his PhD students eventually to do some studies when they looked at cyclohexanone leaching out of the plastic tubing. And that causes loss of taste, loss of short-term memory, cardiomyopathy, and actually causes reduced barophoric responsiveness. So there are a host of chemicals which we expose patients to. And then, of course, there's the inflammatory nature of dialysis. Every time we connect somebody to the circuit, we're activating white cells, we're activating platelets. And so one of the questions, of course, is, well, do these have an effect? Well, one of the effects they could have is that if you looked at vascular access survival, it's much less in patients who dialyse 6 times a week compared to 3 times a week. And most of the access is fistula failure. So perhaps continually activating leukocytes and platelets may cause earlier access failure. And then the other question I've got for you is this. John DeGeerdis gave me this data. This is what happened to the patients after the trial. So if you imagine during the first year of the trial, 2 patients died in the 6 times a week group. 1 patient died in the 3 times a week group. But in the first year after the trial finished, 1 patient died who was in the 3 times a week group. 9 patients died in the group that were dialysed 6 times a week. Why did they die? 7 due to cardiovascular disease, and 2 due to non-access infections. So, more frequent and longer dialysis? Is more always better? Well, there are recognised short-term benefits of blood pressure control and small solute clearances. But what I would say to you is this: the potential disadvantages are certainly poorly studied. They're very short-term. But there are these longer-term questions about whether we are exposing patients to chemicals, to continued activation of their immune system, and increase the risk of access thrombosis, infections, and cancer. Thank you for your attention.
Ερωτήσεις, παρακαλώ.
May I?
Yeah.
Thank you, sir, for your excellent talk. I'm wondering, you showed us the dark phase of dialysis. So this is exposure to our materials and methods. And it was quite evident that exposing more times per week these patients to all these toxic effects would result in some deleterious problems and effects. So that's one way to look at this, and this cannot be disputed. But on the other hand, there has been a comparison with patients that have been doing more frequent dialysis, but not more dialysis. You showed that almost 40% of the patients didn't receive more dialysis as scheduled. So maybe this is quite an unfair comparison between people that were scheduled to do more dialysis, even at the cost of frequently doing that per week, and we're actually seeing the results of patients that did not do more dialysis, just more frequent dialysis. The Canadian experience where we have people had more dialysis in the Toronto area, the Pierre Atos group or Dr. Christopher Chan's group, they have some very interesting results, much more impressive concerning all these intermediate maybe outcomes concerning heart failure, etc.
I think the problem you have to accept is that the data from Christopher Chan and his colleagues, unfortunately, is confounded by the patient choice. So if you look very carefully, the patients who select themselves to do either more frequent or longer dialysis are not the average patient who turns up to the dialysis unit. And therefore you have to accept that that data is always going to be confounded by that problem. And as I showed you, in terms of patient survival, those patients survive much better than the average patient. But they're totally different. And you would therefore expect a totally different survival. Vangelis was talking about the NCDS study this morning, or earlier this morning. If you remember, in that study, the average age of patients was 51. Not one patient was diabetic. And yet, we've used, in inverted commas, KTOV from that study, and we've tried to use that over time to other patient groups, which probably you can't do. And I think that's the same sort of problem we have with Chris Chan's data. But if you very carefully look at what they've published in terms of the actual randomized study, you find that things that Chan reported in terms of a reduction in left ventricular mass is not found in the actual randomized study.
Concerning my first question, whether this is an effect of more frequent use of dialysis, and whereas we don't have the benefit of doing more dialysis, actually in the frequent hemodialysis network?
I think probably the best way to look at that is if you imagine the two more frequent dialysis trials. So if you look at the more frequent daily dialysis trial, I think most of us would probably think that the patients who had the standard US dialysis of about 2.5 hours, 3 times a week, was inadequately dialyzed.
We all know.
Yeah. But if you consider from the nocturnal group, where most patients were dialyzed for about 4.5 to 5 hours, 3 times a week, and you compare those with, if you imagine the more frequent dialysis group, that would probably give you an index of, if you imagine more frequent versus what you call slightly longer dialysis. because the average dialysis time was, I think, around about 4.5 to 5 hours in the nocturnal group. And that would give you, if you inverted commas, the more dialysis time. Those patients probably had the better survival of the two groups. But again, the problem there is that the groups were slightly different in terms of how they were chosen for the two different trials. That's the problem.
Thank you very much for your excellent talk. I would like to take you up on your first notion that you are a clinician. And let me ask you in general, are you suggesting to throw in the garbage the more frequent dialysis overall? I mean, the way I understood your presentation, I mean, apart from showing us the dark side of dialysis, is that we should probably personalize the dose of dialysis and have a good follow-up of our patients. So are you going to do that, or you don't believe in more frequent dialysis in any case?
Okay. I think the issues are that when we survey our own dialysis patients and ask them about symptoms, how they feel about dialysis, the commonest complaint patients have is they feel tired after dialysis. And about 1/3 of our patients only start to recover by the morning after the dialysis. So the way we are delivering dialysis to patients is not helping the vast majority of the patients. So we do need to improve how we deliver that. So what are we doing at the moment? Well, we've done a lot of work in the last 2 years looking at, how we think we can possibly adjust, inverted commas, KTOV. So we're looking at it in terms of energy expenditure on the basis that we think intuitively that people who are eating well and are physically active probably do need more, inverted commas, dialysis than people who aren't. Secondly, we need to move away from just urea clearance, and so we're very concerned about volume control. So yes, we do have patients who are on 4 times a week dialysis, but invariably that's usually for volume control. They're usually elderly, frail patients with poor cardiac reserve, and we do dialyze them more frequently. So, and we also equally have patients who we try and preserve residual renal function on. So we believe in what I call initiating hemodialysis slowly and trying to preserve residual renal function. Everybody doesn't start on 4 hours 3 times a week. So we have a number of patients who will be on twice a week dialysis, etc. So we try and tailor, we think, the dialysis to individual patients and don't have a one-size-fits-all approach. But I think the issues, coming back to some of the chemicals, is that if you look at some of the commercial dialysis companies, they will use a very small volume of fluid to prime their dialysis circuits, and they will only run it for a few minutes. And therefore, that's when a lot of these chemicals will go into the patient. So we would prefer to use a larger volume of fluid and prime the circuits for much longer to try and reduce that chemical exposure to our patients. But it does have a commercial side to it.
Thank you very much for your talk. And at the end, what is your proposal for the dialysis dose, for time and...
For dialysis dose? The simple answer to your question is I haven't a clue. And I think that in the UK, we have had to move to seeing patients once every 4 weeks. And I think that I would like to work in France or in Japan where you can go and see the patient every day that they turn up for dialysis. Because I think, to be honest, seeing the person, seeing how they look, seeing how they respond to dialysis actually is really important, rather than just being somebody who is presented with a whole series of numbers. So I would probably try and tailor the dose according to how the patient was feeling and coping with dialysis.
Well, thank you very much, Dr. Andrew.